Good evening, friends. Welcome to this Tuesday evening academic sessions. We welcome all of you to this academic session. Every time we try to bring some topic of interest for all of you. Today we have it happens to us that Dr. Rajasekara, who is the director of Nephrology department, happens to discuss with me a topic which is probably close to his heart, that is acute nephrology. He says critical care nephrology is very close to him, and he has been participating in international forum discussing about AKI in obstetrics patients, something which is not an uncommon phenomenon which we see day in and out in ICU. Maybe this is one of the common reason why the obstetrics patient present to us in some situations where the pregnancies gets complicated from a the pregnancy-induced hypertensive, preeclampsia. Sometimes we see acute renal shutdown with a massive postpartum hemorrhage, or sometimes the unexplained AKI comes to us and we find some TMA or a TTP or a, now we say, complement associated the HOS. So these are the situations which we come across day in and out. But when he actually told me that he has been a part of an international forum talking about it, I felt this is a right time for us, actually, for him to enlighten us in the city of Hyderabad and in the country of India. So we felt that topic to be a part of our webinar. And again, when I actually thought about this topic, there was no doubt in my mind that if somebody can justify giving inputs, perioperative critical care in that part, Dr. Sunil T Pandya was the none other than a clinician who has been a vast experience with a clinical acumen. With that, we have both of our obstetrics colleague, gynecology colleagues, Dr. Anitha and Krishnaveni ma'am, have been a part of Hitec City, doing a wonderful job in both OBZ and both gynec and OBZ. So both of them will be a part of it. So I welcome all three of you. And over to you, Rajasekara sir. And it is a privilege for us to have you on board, sir.
Venkat, thank you. As usual, you have been teaching us so much on a day-to-day basis. Thank you for all the learning. As Venkat clearly told us, in our country, in our ICUs, it is not uncommon for a nephrologist, for an intensivist, or for an obstetrician to encounter a patient who is pregnant and who has got an acute kidney injury. Unfortunately, if you look at whatever we know till date, there is not been major consensus on several aspects of this particular cohort of AKI, including no consensus on when do you define or how do you define AKI in this setting. So in the next 15-20 minutes or so, I will try to convey what we clinically understand regarding acute kidney injury in pregnant population. And then, of course, we can discuss and learn from each other. Let me start off with a doctor who was P2, L2, full-time normal vaginal delivery elsewhere, and post-delivery had a significant PPH. There, they have diagnosed her to have a renal shutdown and shifted to our unit. We had to dialyze her the minute she came to emergency room. She had severe anemia along with significant leukocytosis. So we considered sepsis as a possibility, postpartum hemorrhage with sepsis, but there was some history of NSAID intake also. Because the investigations revealed a low-grade DIC, we kept sepsis as the high probability on cards. This particular patient was not recovering after 4 weeks of dialysis, and we did a biopsy. As you can see, all the architecture of the glomeruli and the tubules, what we call as ghost glomeruli, are seen. This is low power, and these are called as the ghost outlines. You can just make out the outline that there is a glomerulus here, but you cannot make out the detailed architecture of the glomerulus. This is on past stain, and you can see again there are no cellular details made out inside the glomerulus. The methylamine silver stain showed some fibrin thrombi inside the glomerular capillary loops. So the Mason trichome stain, which we usually use to pick up the chronicity, again shows that chronicity was not much, but the whole thing has lost its viability. So when you get somebody like this, you have a differential diagnosis. You have a PPH, it could be a simple ATN, is what most of us think. But unless you biopsy, you do not know what is the diagnosis, what is the treatment specific to be added, and also how do you prognosticate to the patient's family. And any one of these spectrum, which could be HUS or AFLP or TTP, any one of them can present in the similar way: postpartum hemorrhage, shutdown, anuric AKI, and not recovering even after 2 to 4 weeks of dialysis. So let me shift gears and take you to what we now understand as a staging of CKD. Whenever we look at a patient, we always classify this patient's kidney disease into 5 stages. This is based on the GFR, stage 1 being more than 90 ml GFR, stage 5 being less than 15 ml GFR. What we also understand equally important or more important is the subclassification into A1, A2 and A3. Somebody has more than 300 milligrams of protein loss, we classify them as stage 2 A3. And why this is important is stage 2 A3, stage 3 A1. The stage 2 A3 may progress faster than stage 3 A1, telling us it is not the amount of GFR that determines the progression, but the amount of protein loss. So somebody has more protein loss, they progress faster to reach stage 5. Why am I talking of CKD staging when we are supposed to discuss obstetric AKI? So from 2015 till almost 2020, we had done some screening in the urban slums of Hyderabad as part of the Care for Your Kidney Foundation. And we found that almost 14.8% of this population, which did have no symptoms, this was a population screening, had CKD, either by the GFR criteria or by the urine protein criteria. 57.16% of them were females. And what is important, when you and I look at CKD in our community, we have the classical causes of diabetic nephropathy, chronic interstitial nephritis, chronic glomerulonephritis, or polycystic kidney disease. But we now understand acute kidney injury, which is not recovering, contributes close to 30% of CKD in our community. And when you look at female CKD, most of this CKD would have started off during the pregnancy. They would have had some hypertension, they would have had some protein loss. Unfortunately, when the patient got discharged, they are lost for follow-up. They are again seen during another pregnancy where it is labeled as a preeclampsia because of hypertension and protein loss, and again they are lost for follow-up after the delivery. But this population, because of repeated AKI, land up on stage 5 CKD quite early. So when you see a lady who has come to you with 30-year-old or 40-year-old and the creatinine is going up, there is protein loss, take a detailed history. During pregnancy, they would have been told that there is some hypertension, there was some protein loss, and then they were lost for follow-up because all of us assume everything disappears or recovers once the delivery is done. So when you look at pregnancy-related AKI, the understanding today is it is one of the leading causes of AKI in the developing countries. Equally important is it also contributes to the CKD burden in the population in the women. So what we now understand is pregnancy-related AKI is decreasing in incidence in the developing world. It is increasing in incidence in the developed world. and it also contributes to significant fetal and maternal morbidity and mortality. What we also know is it is associated with long-term effects. When I say long-term effects, we are talking of CKD in the mother and CKD in the unborn child. That means child is born with a low birth weight, subsequently develops in life hypertension early, also CKD early. So this is the importance of knowing a little more about pregnancy related AKI. As I already mentioned, there is a changing trend across the world. You are getting decreased incidence from almost 30% to 5% in countries like India. Published data from 1970 till 2020 that we are improving. We are improving as a country because of the obstetric care that we are able to give. Also equally important of the access to abortions, safe abortions in the population. Whereas in the developed world, there is a significant trend of increasing the incidence across. This is probably because advanced maternal age and maternal age associated with some amount of diabetes and hypertension. And also they may be picking up more often than it was earlier. And I am quoting this from a paper in 2019 that legalization of abortions and improvement in the obstetric quality of care in countries like India has seen a decrease in the incidence of AKI in pregnancy. At the same time frame, they have seen an increase in the incidence in the developed world. So this is a paper from South India, Dr. Gurudev, who heads the nephrology in MS Ramaya. They published in Indian Journal of Nephrology some time ago, close to, when you look at all the AKI, 3 to 7% of AKI in their cohort was secondary to pregnancy-related AKI. And when they looked at their maternal and fetal mortality, it was a staggering 20%. This was published some time ago. I will show you more recent data from city of Hyderabad. So if somebody develops AKI during pregnancy, 20% of these people will die. If the child, if somebody develops AKI, the fetal mortality can be as high as 22%. This is from South India, so very close to us geographically. This data, which was presented this year in World Congress of Nephrology, is from Gandhi Hospitals. They looked at 8 years duration of obstetric AKI from Gandhi Hospitals Hyderabad, and they found out of total 365 pregnancy associated AKI, the maternal mortality was 22%. So in the present day, in the present year, in 2023, if a lady develops AKI, or if 100 ladies develop AKI during pregnancy, 22 of them don't survive. And that's a staggering number. And for you and me to introspect and see how do we improve our outcomes. I'm taking you again to publications from UK, and they have clearly documented that the pregnancy-related AKI is increasing in incidence across Europe. And they found that the factors, when they looked at talking to the ICU people and obstetricians, there is a problem because they don't know when or how to define AKI. There is no consensus on what you call as AKI, what somebody else calls as AKI during pregnancy. The other thing they have compiled in this paper is different countries publishing over a period of time and talking of their incidences. This is a data from more than 32 lakh admissions into the general critical care, out of which they found that 44% were female admissions. And out of this 44%, close to 0.6% were pregnant on admission. So why would somebody come to ICU when they were pregnant? Either because of associated pregnancy related problems, like something to do with preeclampsia or very high hypertension or hemorrhage. But equally important for you and me to look at non-obstetric causes when a patient who is pregnant comes to the ICU. It could be a respiratory cause, cardiovascular cause, GI, or genitourinary, or something else. If you do not know how to handle a patient of pregnancy, you are likely to cause iatrogenic AKI in these people. So leave aside the obstetric reasons like hemorrhage, preeclampsia, but when they come with a non-obstetric reason also, you should know how to define AKI in these people and how to manage AKI in these people. That brings us to, is there anything that we can do to improve our quality of diagnosing pregnancy related AKI? As we already discussed, there is a huge burden and it is not like the problem today and disappearing tomorrow. It contributes to a lot of CKD in the community in future and also affects the long-term outcomes in the children born out of a pregnancy related AKI. Unfortunately, as I already told you, there is no validated definition of AKI in pregnancy because when you use the KDIGO definition, you are either looking at the creatinine or you are looking at the urine output criteria. Unfortunately, our pregnancy, non-pregnancy serum creatinines are totally different. So which one do you use when you call them as AKI? So we don't know the previous value. It becomes extremely difficult to say this is AKI, and therefore we may be not picking up AKI early enough in pregnant people, thinking that we have to wait for a particular amount of serum creatinine. So it is difficult to know a baseline pre-pregnancy creatinine. So it is also difficult to diagnose AKI early during this time. And there are so many changes that happen in pregnancy which make us difficult to diagnose AKI because you know that the normal GFR in pregnancy increases significantly along with so many other changes. I'm quoting a paper from the Albert Einstein Institute in New York, who published on AKI in obstetric patients. This is a very good paper, especially for students to go through. They have summarized what we know presently regarding the changes in kidneys, physiological and also pathophysiological changes in pregnancy. And then how do we classify this AKI into different compartments? What are likely to be the causes depending on which part of the pregnancy that the patient has presented to us. So to determine the cause, you have to look at a patient, which semester the patient has come to us or trimester the patient has comes to us. Pre-renal being more common during the early pregnancy, renal and post-renal being more common later part of pregnancy. But there are certain lesions like preeclampsia, HELP, TTP, HUS, acute fatty liver, where there is an urgency in making a diagnosis because the outcomes like mortality and morbidity are affected, and earlier picking up makes a huge difference to the outcomes. So as we discussed, it depends on what trimester the patient has come to us, and depending on when you see the patient, you can have a differential diagnosis for the AKI. Let us discuss another patient, a 20-year-old lady, 35 weeks gestation, primey, referred to us with hypertension and protein loss, and had a hemoglobin of 8, platelet falling, creatinine 4.5, with a bicarbonate of 15, obviously in the ICU. So when more than 20 weeks pregnant, somebody comes like this, we have to look at how much protein loss, is there other organ involvement, if there are low platelets, elevated liver enzymes, and of course, creatinine is doubling, we do talk of severe acute kidney injury or AKI stage 3, and the differential diagnosis to some extent is clinched by the investigations that you look at. I'm not going into the details of the investigations, but you and I have to be clear in our minds that this patient can have a simple preeclampsia, can have HUS, can have a PPH, or it could be just a sepsis causing AKI. Any of the autoimmune disorders like lupus, which can flare up during pregnancy, can present like this. Always rule out a obstruction, and there may be indication if the patient is not recovering. Nowadays, up to 24 weeks, we do a biopsy. As you saw in the first patient who was a doctor, postpartum AKI, biopsy clinched the diagnosis, giving us that this patient will not come off dialysis. So we can prognosticate to the patient and then plan for long-term dialysis versus kidney transplantation. So let me discuss next 1 or 2 minutes about a AKI patient in pregnancy. Can we biopsy these patients or not? As I told you, around 3 or 4 lesions, there is an urgency to know histologically where we are, both to diagnose and treat and also to prognosticate to the family. Most of us are now very comfortable to biopsy up to 24 weeks of pregnancy. Literature also talks about the safety. So it can be performed up to 24 weeks, usually in a sitting position if it is advanced pregnancy. And then if there is a rapidly progressing renal failure, obviously you want to know the diagnosis before giving the patient high toxic medicines like immunosuppressive drugs. When you biopsy, most often in a AKI in pregnancy, if they are not recovering, up to 2 weeks, we don't wait any longer nowadays, you are probably thinking of acute tubular necrosis. Unfortunately, most of the ATN that you think is ATN is not going to be ATN. You are going to get either TMA or acute interstitial nephritis, which will progress very fast to end stage in 4 weeks, or glomerulonephritis or cortical necrosis. So this particular patient, which I mentioned, 30 weeks pregnancy, underwent dialysis, a cesarean section was done, a live baby was delivered, but the kidneys never recovered. You see the CT scan film next to it, and you see the halo that around the cortical area. Subsequently, we did a biopsy and found that though we could successfully bring out the outcome in delivery, patient's kidneys had gone into cortical necrosis and this patient never recovered, went on dialysis long term. So let me quickly talk of another patient who came to us, and 30-year-old lady, primey, total anuria, had undergone 24 hours ago cesarean section. There was intraoperative some bladder injury. When we saw the patient, creatinine was 5.5, and look at the CT scan, there are normal bulky kidneys that you can make out. And when further cystoscopy was done and we could not delineate the ureteric orifices, percutaneous nephrostomy was done on both sides. And when you look at the percutaneous nephrostomy, there is a abrupt cutoff of the ureters above the bladder, which suggests that there was probably tying of the ureters. So this is a post-renal AKI, totally anuric, secondary to surgical tying off of the ureters. So when somebody comes to you with a total anuria, severe ATN is a possibility, but you have to keep in mind like TMAs, TTP, HUS or atypical HUS, they also can present like this, but rarely there could be a ureteral injury which is totally reversible. This particular patient underwent a procedure and totally came off dialysis subsequently. So absolute anuria, vascular catastrophe like bilateral renal artery thrombosis is a possibility. Cortical necrosis, as you have seen in 2 of the patients I have discussed, and of course the third patient has a urinary obstruction. So if you look at the later data from Hyderabad, pregnancy-related AKI from Usmania in Hyderabad, you look at total 395 patients they have compiled in 10 years. And the commonest reason why these people had a AKI was preeclampsia. So more than 45% of people, when they had a diagnosis of pregnancy-related AKI, had preeclampsia. Next commonest reason was sepsis, 33%, antepartum hemorrhage, postpartum hemorrhage, 8 and 12% respectively, HUS was seen in around 9% of people. Obstruction, which we just discussed is a rare cause, was seen in 2% of the 395 people. When this renal AKI was biopsied for the same criteria which we just discussed, 2 weeks of non-recovery, what is the commonest lesion that you will come across? The commonest lesion that was seen, unfortunately, was patchy cortical necrosis, which was 26% in this particular cohort. So if a nephrologist decides to do a biopsy for non-recovering AKI in pregnant cohort, it is likely that these patients will have a serious lesion like patchy cortical necrosis. But you look at the other group, which is 24% diffuse cortical necrosis. These two are little different to us because when they have a patchy cortical necrosis, the chance of recovery from dialysis is very high. They will come off dialysis, but their creatinines will never become normal. They will stay around 2.53, and later on in life, again, they may go back on dialysis. Whereas diffuse cortical necrosis, which you saw in 2 of the patients we discussed, never recover from dialysis. They will go on long-term dialysis from day one, and they will need a transplant as early as 3 months from the lesion that the patient comes to you. What were the other lesions Usmania group found? So acute tubular necrosis was third common reason. This, if it comes on biopsy, we are happy to tell the family, you just wait for some time and the kidney will recover. Even this group in the ICU, the intensivist, obstetrician, and the nephrologist should be careful because severe ATN leading to dialysis requiring AKI, if you don't dialyze them properly, if you cause them to have hypotension, you don't know how to remove fluid during the dialysis, how to give other medications, you can make them to go into permanent dialysis also. The other less frequent lesions were FSGS, TMA, endotheliosis, and IgA nephropathy, which were less than 5% in this group of patients. So once we know the diagnosis, and I quickly told you regarding the problems of definition, which trimester patients are presenting, what are the parameters you look at, and then if necessary dialyze, and if necessary biopsy. How do you manage these people? The cornerstone of management will be these 4 things. Drugs, you should know what to give, when to give, how to give, and how much to give. You cannot be giving them like any other ICU patients. Dialysis, dialyzing a pregnancy in pregnancy is a totally different ball game, and you cannot dialyze these people. As I just mentioned, you may cause them to become chronic lesions when they are actually acute lesions. And when do you deliver these people, and what is the diet that we need to give them? So drugs, I will not be able to go through the details because we know a lot today compared to even 5 years ago regarding pregnancy and AKI and what medicines and how to give, including we have some experience with eculizumab in Hyderabad, though it is extremely expensive. So it is important to think of cause and then give medications or the prescription. Things like plasma exchange may give us life-saving modalities in this group of people. Indications for dialysis, as I already told you, you don't wait like in other people for a complication to occur. You throw the data on early dialysis being not helpful in ICU out because pregnancy is one condition where you want to really start early and forget about the literature because pregnant ICU patients are a little different compared to others. So pregnancy AKI is different. There are several papers which talk about the reason to initiate early RRT in a pregnancy-related AKI. We will not have time to go through the details of these data, but please note that pregnancy has no renal reserve. When I say pregnancy has no renal reserve, I have to explain a little about what do we mean by the reserve in a kidney. Most of us, when we have a baseline GFR, you can actually increase your baseline GFR when there is a need. Just like when you run, your heart rate increases. When your kidney is stressed, your GFR increases. And we now know that this reserve in GFR is what protects you when you go through an insult, like a surgery or a drug or a contrast also. But in pregnancy, I'm skipping data on what we know now about the renal reserve. But in pregnancy, what happens is we don't have any renal reserve. Most of our GFR is already recruited, and that is why as soon as pregnancy occurs, the GFR increases. There is no reserve. Whereas in normal people, you may get a reserve which you can recruit for during an insult. In pregnancy, all the reserve is used up. Therefore, these people are more prone for complications, though you may think that RRT, even if it is late, can not change the patient's outcomes, but there is clear data which talks about the mortality in the fetus and the outcomes in the fetus change if you don't change the uremic milieu early. So you don't wait for a particular level of urea or creatinine. You have to do more frequent dialysis. We usually do, if somebody is pregnant and dialysis and AKI, at least 5 days a week. And you don't remove too much fluid in too little time. You don't want to cause sudden shifts of fluid in the body. You may use less anticoagulation or no anticoagulation. And you can give them erythropoietin if the AKI is prolonged. You have to take care about intensification of dialysis, the membrane of dialyzer being biocompatible. You have to do what is called as a low flow, low efficiency dialysis for these people. Erythropoietin can be given, it doesn't cross the placental barrier. And nutrition, you have to take care during dialysis in pregnant women. You have to think of trace element supplements. Protein, you never restrict in any AKI, especially in pregnancy related AKI. There are some recommendations about BP control during dialysis and even on the non-dialysis days. And as far as modality of dialysis is concerned, Indian nephrology community has experience with almost all types of dialysis, including CRRT and of course SLED. The data I'm showing in front of you is from Hyderabad. 1,000 dialysis for AKI in, if you look at, around 112 of them were during pregnancy AKI, and Hyderabad city per se has experience with IHD, SLED, CRRT, even pregnancy in pregnant, even PD, peritoneal dialysis in pregnant AKI women. Regarding timing of dialysis or timing of delivery, we again have no consensus. And if you look at the various international societies, talk of various different guidelines. Some talk of below 34, some talk of 34 to 37, and some talk of waiting up to 37 if there is no emergent indication, which is BP uncontrolled more than 160 by 110, fetal distress or worsening vision or eclampsia, organ dysfunction like pulmonary edema or anything else. So it is a condition where we don't know much, but we now know that short-term outcomes, long-term outcomes both get affected by pregnancy-related AKI, and people who handle these patients, including nephrologists, intensivists, and obstetricians, should know more about this particular cohort of AKI. What happens to kidneys? So several authors have published now, when somebody delivers and we think that they become all right, most of them actually develop chronic lesions in the kidney. So over next couple of years, even as early as 1 year after the delivery and recovery, when people are looked at, they have had new onset proteinuria, new onset CKD, and if they are not treated properly, they can progress very fast to end stage. That's not all. Even in the child born, you do get a incidence of CKD being much higher in this particular group. So now we know all AKI shifts into AKD after 7 days, and at 90 days becomes a part of the spectrum of CKD. So it is very important that these people, when you discharge them, you tell them to go back to OP and follow up, looking at the quantity of protein loss, their baseline GFRs, hypertension control, salt intake. Though there are several things now published as guidelines, how do you follow up these people post AKI? So to conclude, pregnancy-related AKI is a big problem for us. If we don't know enough, we are likely to contribute to more harm and more long-term outcomes. You need to learn to detect AKI very early in this group, and you have to identify diseases like preeclampsia early and get a team which is has the wherewithal or expertise to treat these people. Please look at delivery as an option to improve the recovery rate. Drugs, you should know more about them during pregnancy and AKI. Diet, never restrict protein. Dialyze early, dialyze intensively, and don't cause too much fluid shifts in these people. And long-term follow-up is extremely important so that they don't become part of the CKD burden of the country. Thank you very much.
Thank you, sir, for that overview. I think you enlightened and covered all the concerns. Coming for the discussion, we have Dr. Anitha, who is our obstetrician and gynecologist in Hitec City, and we have Dr. Sunil Pandya, sir, who has been a part of critical care, as I mentioned. For both of you, ma'am, one after the other, we have seen from the different literatures, the acute kidney injury incidence in a perioperative period varies between 1 to maybe 2% in many of the Western countries or developed countries, where the facilities of obstetrics care or a peripartum care has been optimal. But the same scenario is not true for Indian context. When I reviewed many of the literature, it can go haywire between some 1% to 10 to 14%. So it can be varied because the healthcare system is heterogeneous in the countries like India. So what is your take, Dr. Anitha, on that?
Thank you, sir. Good evening, sir. Rajasekara is a wonderful presentation. It was an eye-opener for all of us today when we look into the AKI and pregnancy. Well, sir, it's very important for us to understand that are we really dealing the population of our obstetric care completely to reach out high-end facilities is first thing we have to think about. The biggest thing is that there are areas of expertise where, for example, the government of India has made a safety method like a MTP Act, which has come into the place, making this incidence of increased incidence of sepsis during miscarriage as an open platform where a woman opts for an abortion can go safely for a medical abortion. That incidence has drastically decreased. Similarly, the antenatal care has drastically improved in various perspectives and aspects. But the patient who is coming to us, already they are pregnant, either the pre-existing medical problems, even though they have it, they are not followed up, or by the time they reach us, will be already pregnant. Second, as a lacking thing is that in a standard protocol of an antenatal care, we have a standard set of investigations which we evaluate. For example, we do a hemoglobin, we do a serum creatinine. We don't have a complete panel of workout to understand whether we can pick up high-risk pregnancies for an AKI injuries. Third is that, do we really have that approach wherein high-risk pregnancies, especially when we have previous history of PIH, previous history of hemorrhagic shock, or previous history of chronic recurrent pregnancy losses, where those patients who are supposed to come for a follow-up, we have a drop-downs. So it's not the care is not reaching, but the complaints of a patient is not up to the mark. And even for a simple hemoglobin test, by the time we see most of the pregnant ladies, we hardly get any hemoglobin test from them. I'm talking about in general obstetric care, not in a high-end tertiary center or a private hospital or a big quaternary hospital like Yashoda Hitec, because people are quite educated. But in a population of a women in general, what we are reaching out is that by the time they come up, they're already established pre-existing medical problem, already in a situation wherein they have a criteria, either they are nutritionally very poor, severe anemia, PIH, and these are the background which superimpose medical problems, due to which our incidents are really little more high when we look into the US UK standards.
Okay, Sunil sir, you must have been seen probably for the last 2.5 decade to 3 decade of perioperative critical care, where you have seen the spectrum of AKIs. So as there are few points which has been highlighted by Dr. Chakravarti's talk, that the normal creatinine in a first trimester, second trimester can be different from what we see in a normal, otherwise healthy woman. So 0.3 rise from a 0.6 to 0.9 or 0.6 to 1 may be considered normal in many circumstances, which may be an initial clue of an AKI. That's what one of the point he highlighted in his talk, that the creatinine need to be taken care. In the same way, Dr. Anitha pointed out ki the heterogeneous healthcare system, from a extreme tertiary high-end care to a grassroots level PSC, there will be variation in the way we evaluate, the way we care. So what do you think is the cornerstone? Why we have such a rising incidence of pregnancy related, that is PRACI, right now in India?
See, one of the things that I have recognized during my last 2.5 decades is hesitancy to evaluate. See, most of the time, pregnancy is considered to be something like normal physiology, or actually normal physiology. And the first trimester investigations invariably just includes CBC and TSH and probably CUE. Especially unbooked case with a creatinine of 0.7, it is still normal as per the range. But we don't know, like we know, as you rightly said, 0.3 is considered to be the normal because of the increased GFR that we see, or increased renal plasma flow that we see in pregnancy. So unless we change the protocol and it as institutionalized as a part of FOXI guidelines or PIGO guidelines, that yes, at booking in the first trimester, these investigations have to be done, which includes, because creatinine is a delayed marker of acute kidney injury. We all know that. So protein creatinine ratio, which again indicates early detection, as well as at least the creatinine can be done at booking itself, and subsequently can be followed up. So we have a baseline. And importantly, we are seeing a paradigm shift in the types of cases that we are getting currently, like because the high risk, especially because we are in the tertiary care center, a significant load of high-risk women, advanced maternal age, pre-existing diabetic, chronic hypertension patients. So already they have a significant chunk of, Rajasekara must be knowing, a significant chunk of connective tissue disorders complicating pregnancy. So already they have pre-existing pathology which predisposes. But one of the things that I always remember is if the patient has previous history of preeclampsia, the incidence of AKI is significantly high. As intensivist, we also have to remember that preeclampsia, again, it affects 15.3 to 16% of patients with preeclampsia, they have acute kidney injury. So that entity cannot be taken for granted. And if you have preeclampsia with HELLP syndrome, without AKI, with AKI, again, the morbidity and mortality raises. Like if you have preeclampsia HELLP without AKI, if you look at the incidence of abruption is 11%, incidence of major hemorrhage is almost about 12%. But if the patient has HELLP with AKI, abruption incidence is almost doubled, 22 to 24%. Even MOH, like massive obstetric hemorrhage, also is doubled, indicating that the further insult to kidney, already pre-existing damage can occur, which again ends up with long-term dialysis. So we need to have a screening, early trimester screening at booking, and subsequently should be followed up very closely, especially if the participant has multiple risk factors which can worsen the renal function.
Rajasekara sir, can you be on board? Sir, sir, unmute yourself. Sir, you actually give a scary statistics of around close to 20% of the AKI who were pregnant. We are losing them during the course of the illness. So that means the AKI is as harmful. What we see in ICU also, the moment a patient had an add-on AKI to my ICU patients, that increases my mortality. So the question, I think the discussion from Dr. Sunil Pandya sir and Anitha ma'am is that, should we have the screening tools? And again, the screening tools has been again under the question mark. The creatinine, is that a right screening tool? CUV, again, we see some amount of proteinuria and a dipstick, which can be physiological in the pregnancy. So where do we stand? How do we actually make it better? See, we always are concerned about the rising incidence of pregnancy-related acute kidney injury and also the mortality related to this. But how do we actually solve it with such a heterogeneous Indian population?
To start off, Venkat, aim was not to give a scary picture. I just chose in the chronology things which we are not very clear about. Till date, there is no consensus on definition of AKI in pregnancy. Similarly, we don't know when to biopsy them. We don't know how to dialyze them. We don't know how to follow up these people. So I didn't want to spend time on pathophysiology and placental insufficiency, all those where we now know enough. We know what are all the soluble factors which increase in the plasma and cause these changes. Where we need consensus are these broadly 4 or 5 topics, and there is published data from across the globe, including our country. So you may be aware we are going to do the ADKI in January on obstetric AKI. I'm hoping that post ADKI, our publications will definitely tell us some guidelines on how to do these things. So as far as now, the minute there is a pregnant lady, and this is at the level of the obstetricians and gynecologists, every month, if there is even a history that patient had a preeclampsia earlier or protein loss earlier, simple hypertension, all of them need to be followed up on a monthly basis. And even Anitha, myself, Dr. Krishnaveni, myself, we have all managed patients who had established CKD, 2-3 creatinines with successful pregnancy outcomes. That's because monthly you are able to follow them up, do a list of do's and don'ts, salt restriction, BP control, and then as soon as there is a problem, they come to the hospital and they are kept in the hospital till the delivery. So I believe we do know enough of how to take care of these people. We just have to pick up early, make sure intensively they are followed up, and then as soon as there is a need, you should not hesitate in dialyzing them. You should not hesitate in biopsying them. You should not hesitate in delivering them. These are the cornerstones, I think.
Coming back to sir, Sunil sir, we see these patients in peripartum situations where one of the commonest reason in peripartum situation is PPH or a abruptio placenta leading to a acute kidney injury post-operatively because of many reasons. One of them is hypovolemia, pre-renal, or massive hemorrhage induced DIC and all. So you must have been seen a wide spectrum of causes in them. What is the burden of AKI related to a PPH or a peripartum hemorrhage?
So invariably, when the mother is in class 4 hemorrhage, especially with whatever may be the etiology, there is always a little bit of renal insufficiency sets in. So what we need to do, or what we do, is we just have to adopt to advanced hemodynamic monitoring tools so that we can do adequate volume replacement. Because suboptimal volume replacement can worsen ongoing pathophysiology. Importantly, upon this, at least I've seen few of the referrals that have happened to us, as even Dr. Rajasekara Chakravarthi pointed out. For pain management, they give NSAIDs. Even a single ampere of diclofenac sodium can be lethal in such cases when you already have a pre-existing insufficiency and you give NSAIDs. So again, education is of paramount importance. Third thing that we have seen is when you have array of hypertensive spectrum where you have elevated liver enzymes, LDH is elevated, and parameters are deranged, platelets are low. These are the things, differentials that are seen in sepsis, that are seen in HU, as HUS, that are seen in AFLP. But importantly, very few of us have, most of us, we have a very high threshold to send ADAMTS 13SA, which can be a clincher and tells us the right modality of dialysis. Because if you go on a conventional hemodialysis in a patient with AHUS, you're significantly increasing the renal morbidity from the renal viewpoint. Currently, yes, earlier this test assay was not available, but currently we have that availability in most of the centers. And one should have low threshold when you have elevated LDH, especially when the LDH is in thousands. It could be AHUS or TTP, and early plasmapheresis and right modality is of paramount importance. So volume correction with advanced hemodynamic monitoring so that we can minimize renal insufficiency due to volume loss, and subsequently avoiding NCRs in this subgroup of patients is of paramount importance in prevention of AKI with PPH.
What I will be pinpointly asking you, sir, in a setup of obstetric care, preparing for a massive transfusion, getting ready with antimat and PP postpartum hemorrhages or a abruptio placenta with an adequate team and massive transfusion protocols in place, do that actually prevents a AKI? Because that is the one area where there is a huge gap between many what you say developed countries to us. Is that one of the other things? For example, you go to HUS, you go to TTP, you go to TMS and other things, where as a clinician in the perinatal period or antepartum period, you don't have any way to actually pick up them or prevent them. That happens during as a trigger from pregnancy. But these are all preventable causes.
Yeah. So if it is purely atonic PPH without underlying abruption, then yes, it can be prevented. But suppose if there is an underlying abruptio placenta with major obstetric hemorrhage, massive obstetric hemorrhage, then to an extent, because of the release in cytokine factors, already renal insufficiency, not because of volume depletion, but also in addition to the insult because of abruption. So without abruption, massive hemorrhage, atonic PPH, hardly we see any renal insufficiency. Most of them, I would say 99% or more than 99% they recover. But if the abruption is the cause, massive abruption, I won't say subclinical abruption, but it's a massive abruption, then definitely we need to follow up this patient for a longer time, so that even though creatinine may not rise or creatinine may turn to 1.1, but still you need to be under the radar. Patient has to be under radar so that appropriate intervention or GFR estimation can be done, and preventing fracture can be optimized. Like
Anitha ma'am, for you mentioned about you evaluate these cases who are actually pre-existing, having a preeclampsia history or a history of recurrent abortions, or these patients as having any autoimmune disorders. These are the patients where you will be more careful and all. So Dr. Rajasekara Chakravarthi also told both of you happened to actually manage few of the cases who had already a pre-existing kidney disease. So how frequently you come across these cases? How frequently come up the AKI which developed during your pregnancy? Unmute yourself, ma'am.
Sir, ours is a very referral center and high risk center where we have managed many such cases with the team. It's very important to understand that whenever we have an high risk mothers like autoimmune diseases or an SLE or previous history of recurrent pregnancy losses or a PIH who are really high risk category for AKI, we have managed together. It's very important that we need a team approach with the nephrologist, obstetrician, neonatologist, intensive care during pregnancy and antenatal care. Second important thing is that these patients have to be under care since the moment they are pregnant, and the visits will be very frequent. Their investigations, the blood parameters, blood workups will be very frequent. Obstetric perspective, we have some basic workups like we do an ultrasonography. For them, it becomes more frequent with Doppler studies and interval growth scans. Related to the blood workups, also we have to do every frequently 2 weeks once. Patient are already having the pressures and on the antihypertensive, it's very important for us to be vigilant, teach the patient, counsel the patient, and also give them the warning signs of any worsening of the diseases and evaluate them. So their antenatal checkup starts from as soon as they are pregnant, and every trimester things will change. As we all know that the physiological changes in the pregnancy, in the renal parameters workup, as sir also Pandya sir also told that serum creatinine level, what we take it for a normal non-pregnant woman is entirely different than what we take it for pregnant women. And especially when a patient is already a case of pre-existing high risk factors, we have to take that as a level of care, not standardizing. So this laboratory thing is also very important because every laboratory doesn't give a pregnant and a non-pregnant status, especially when we're doing the blood workups related to pregnancy with AKI or a high risk pregnancy or a nephropathy with pregnancy or a CKI, CKD with pregnancy. So these patients are very high risk for IUG, early delivery, complications during pregnancy, during delivery and post-delivery. Hence, for them, it is a multidisciplinary team approach with a high-end care in a unit to continue supervise the patient. This is the care what we have given to the patient, and most of the patients have done really good under the team approach and given a live birth. And post-operative or post-delivery, it's very important for a long-term follow-up not only for this pregnancy, for the subsequent pregnancy to prevent recurrence of the CKD or a recurrence of AKI again.
Rajasekar sir, you pathophysiologically biopsy wise, you have shown us a spectrum of pathological findings, including you said patchy cortical necrosis, diffuse cortical necrosis, ATN, acute interstitial nephritis, glomerular nephritis, and all TMA in that. And if I look at them, diffuse cortical necrosis and probably the category where you have a less TMA. These are the category which you said there are less likely chances that there is any chance of their renal recovery. You need only to prognosticate. Whereas the other component which you pointed out, acute tubular necrosis, if managed well during the period of their recovery, or AIN, if you intervene appropriately and probably treating them, these are the categories. So if I look at your slide of, if I remember the slide, 50 to 70% has some irreversibility. If I see patchy include in that of irreversibility, 50 to 70% comes into irreversibility. Somebody develops an acute kidney injury going into AKD in a pregnant situation or a peripartum situation, something which is more inclined towards irreversibility, is that histopathology suggests?
So I should caution, this data is on people who had significant AKI and there was no recovery for more than 2 weeks. That was the criteria followed both at Gandhi Hospitals and Usmania. We don't have this amount of data, but we had around 37 people as a thesis given to one of the students. When we followed up, it's very, very close to what you have seen. Majority of the non-recovering AKIs in pregnancy post 2 weeks to 4 weeks, if you biopsy, you will find some form of cortical necrosis. If you miss a ATN or a AIN or a crescentric GN, please note that all autoimmune diseases, there is a significant worsening during pregnancy. Somebody may have a very mild lupus, not even presenting symptomatically, but the minute the person becomes pregnant, the humoral immunity gets stimulated. The cell-mediated immunity gets suppressed. So all the autoimmune lesions will worsen. So when somebody comes to me with a pregnancy, hypertension, protein loss, active urine sediment, creatinine not going up much, I'm still worried because I have to give a diagnosis, a label, which I don't have. It will be a asymptomatic protein loss or asymptomatic hematuria. In a pregnant woman, it becomes very, very significant. So before that 24 weeks, which literature now says is a cutoff, I want to biopsy these people. And on paper, I know if there is an ongoing ongoing CGN or it's a pure preeclampsia. If I don't see the patient at that point in time, already established AKI, dialysis requiring 2 weeks not recovering, then I would again want to biopsy. So this particular data you are seeing is on non-recovering AKI for more than 2 weeks.
So we don't know the first part.
We don't know the first part. There will be a significant people who are improving.
Recovered. So the second part is the TMA related component which you mentioned. And Dr. Pandya clearly said that in a case of a PPH, which is because of atony is a different, but in a situation where there is a massive abruption, and there it is not just the bleed, but the pathophysiology of abruption itself with endothelial concern can be a cause for a TMA. And there has been a close relations to that. So he already pointed out that is again comes as a non-modifiable factor in a pregnant situation. So any comments on that TMA's recovery? Because many of the patients who has been referred to me, and I happen to be a part of a case which was there in Srikakulam, where one of my junior colleague was called me regarding that, when I strongly suggested, learning from your lessons, that you should do a biopsy in that patient to at least give a guidance where we are, anuric dialysis for a couple of weeks. Since they turned to be a TMA in that case. So what is your take from a TMA point of view with these patients?
So among the lesions I showed, TMA is not uncommon. If I remember right, around 9% of our patients who are pregnant AKI may have TMA. Our own experience has been they don't go on permanent dialysis. They do recover. You just manage them supportively, control the blood pressures, avoid further insults, but they never recover to normal renal functions. They enter into a spectrum of CKD, stage 3 or so, and they go on like that for some time, depending on how you manage this TMA. It is also true, forget about the pregnancy cohort. If you see any AKI where you biopsy and there is a TMA, we always try to get to the bottom of why TMA in that particular patient. So if they are hypertension induced TMAs, they do very well. If they are autoimmune induced TMA, they do well when you diagnose and treat. But there are other TMAs which are associated with the underlying condition. Like COVID, Hyderabad city had a data of 109 biopsies, COVID induced AKI. So this was presented somewhere and now it's a publication. All the TMAs in COVID, they didn't do well. They went to stage 3, stage 4 and never recovered. So I think TMA is a very syndromic lesion. It is a spectrum and you have to get to the bottom of the cause of TMA.
When we have seen some drug-induced TMAs, including your immunosuppressants.
Yes, tacrolimus and cyclosporin. So they do well. The minute you withdraw, they generally do well.
The other interesting point, which I think of all of our interest, including Dr. Sunil sir, which pointed out, they are HUS and TTP as a spectrum in pregnant ladies. Pregnancy is again a risk factor which triggers this both. As he was pointing out, Adam TS13 will generally in pregnancy is a physiological condition where it goes down and it triggers a TTP or a HUS in pregnancy as a risk factor in them. So again, we categorized them by sending Adams TS13 or it is a TTP or a HUS. And we are now saying TTP is more like you do a plasma exchange and all. And if it comes to HUS, where there is a predominant renal involvement, not like a TTP, and if it is a complement mediated induced by your pregnancy, then probably your maps, occlusive maps and all come into play. But I happen to see recently in the rounds, the discussion that we see a lot of spectrum of the HUS. It's not just a complement mediated HUS, but we in Indian context, we see some subgroup of HUS where you still do prefer a plasma exchange in them over occlusive maps. So we just wanted probably your experience on that and you maybe giving insight.
My understanding is HUS that we see in ICU, there is so much of overlap. A simple sepsis also masquerades like an HUS. You get a low platelet, you get a hemolysis, and then LDH is going up. So I think some of the units are comfortable looking at the level of LDH and offering plasma. And it would have been a contraindication 5 years ago in sepsis. But even in sepsis now, there is data to support in a cohort of patients at least giving plasma. So I believe if you are making a diagnosis of a TMA or a HUS, sometimes to say purely it is in this compartment is very difficult. There is so much of overlap and sometimes autoimmune could be a reason. So I believe whether to offer plasma or not, you cannot decide by just a diagnosis of HUS. You'll have to take many other things into consideration.
Sunil sir, you must have been seen many situations. Now we are saying TTP is a more indication for a plasma exchange, whereas HUS has been put into another spectrum.
Yeah.
And you see, so what is your experience of doing a plasma exchanges in them after doing Adams 13, whatever is possible?
Yeah, see, we have had a series. In fact, we used to refer our cases mostly to Rajasekara when he was at CARE earlier. And there was a good outcome with plasmapheresis. In fact, Dr. Rajasekara can recall many cases which we thought it was HELLP syndrome and subsequently turned out to be because the LDH went on in thousands, 5,000, 7,000, then pointing towards more towards HUS type of entity. And then empirically, they started plasmapheresis and there was remarkable improvement. One case, yes, we have had eculizumab we could use phenomenally expensive, but there is a lot of data. I know Dr. Jagar will be a better person to throw more light. But when HUS is there and you start this monoclonal antibodies, eculizumab, the long-term progression of kidney disease is less relatively when compared to vis-a-vis when this medication is not started. So probably there is definitely a role of eculizumab in this entity, provided we rightly pin the diagnosis.
So there will be a lot of overlap, as already been pointed out, HUS and HELP. We see some amount of hemolysis going on, thrombocytopenia be a phenomenon. And it's not uncommon that a pre-eclamptic lady also can have a HUS. So as he pointed out, there will be a lot of overlap. Sir, what is your way exploring HELP and HUS?
Yeah, one of the important things that we need to realize is moment the placenta and the pregnancy is out, the pregnancy is terminated. I would say 80 to 90% of HELP syndromes, AFLPs, they come back to normalcy, or they at least we see the receding trend. But within after 72 hours, if the trend is not receding, then you need to think beyond HELP. Is it HUS? Is it sepsis, or is it something else? So we need to have alerts. Always don't work in a with a closed tubular tunnel, but you need to have a wider differential diagnosis so that if the parameters do not regress, if the output is not improving, or if the creatinine doesn't return to baseline, then we need to work this a patient and have a low threshold to follow up further, and probably 2 weeks or 3 weeks we need to plan for a biopsy so that we can linchpin the diagnosis. I remember at least the data that we strongly have is a good antenatal care. Like even if you have a signal, almost about 65% of our pregnancy is a high-risk pregnancy load. If you look at the incidence of renal replacement, kidney replacement therapy in pregnancy, booked cases, I would say virtually nil requirement of kidney replacement therapy, despite all the risk factors that we enumerate. And majority of the time, when the patient needed replacement therapy, most of them were referrals, late referrals. So by then, automatically they have come into established organ dysfunction. So there is no other option. So early pickup, early aggressive therapy, early termination of pregnancy, judicious volume replacement are the keystones of prevention of AKI. And HELP, yes, if the parameter does not improve beyond 72 hours, open up your differentials and work up the patient.
So your approach will be, if you are overlapping somewhere, terminate the pregnancy in view of your AFLP and HELP or pregnancy associated all complications. Yeah. And that is the treatment, main modality of treatment for your progression. That doesn't happen and it continues, you keep on looking for other causes, then
absolutely.
Okay. Sir, Dr. Anitha and Dr. Rajasekara, sir, very commonly, any of these patients, when they come to our ICUs, the provisional diagnosis given in the referral center is sepsis. Sepsis, multi-organ failure, the reason is a fever, leukocytosis, acute kidney injury, and acidosis and all. But when I see these patients has no CIRS, hemodynamically stable, we send a repeated cultures, we don't grow anything anywhere, we don't find a focus. Repeatedly, they do a high vaginal swab that grows on and out, but the whole wound looks healthy. In these situations, this is
Venkat, not. Dr. Krishnaveni has raised her hand. I think she has something to add to the previous.
Yeah. Ma'am, you can switch on your camera, ma'am. Dr. Krishnaveni, can you?
Yeah, yes, sir. Yes, sir. Just I was in the section. Meeting comes. If they had the AKI, can you hear me, sir?
Yeah.
Yeah, we can hear you, madam.
Okay. So if the lady had a AKI in the current pregnancy, sir, and what are the precautions we have to take for the future pregnancy, sir? And obviously, if she goes for the renal transplant, like how many years we can wait after the renal transplant so that we can counsel them for the next pregnancy?
Rajasekara, sir, I think it's a...
I will answer the second part first, madam. All our transplant recipients, we do counsel them when ladies go for transplant. First 2 years, we don't want them getting pregnant. My personal bias is after 1 year, we should be able to take them for pregnancy. But most of us, and what we on paper, it is 2 years. The main reason for this 2 years is they want the person to be on stable immunosuppression before we make any changes. The minute we tell them that you can become pregnant, we are supposed to withdraw mycophenolate from the drugs for which are given for transplant and switch over to azathioprine. So patient can continue steroids, patient can continue tacrolimus or cyclosporin, but mycophenolate does not lead to normal pregnancies. It can cause problems. So we withdraw and then tell them you can start planning pregnancy. Because we have to withdraw mycophenolate, we are supposed to wait for 2 years. By then the patient will have got stable immunosuppression and then we allow them to go for pregnancy. The first part of the question, if they have had a AKI in one pregnancy, what I was trying to convey, which we were not doing all these years, is at the time of discharge itself, patient has to come back after 1 week. At 1 week, patient is all right. I want to see them at 1 month. At 1 month, I will be looking at estimated GFR, blood pressure control, salt restriction, and protein quantification in the urine. If all of them are addressed, we tell them come every 3 months. So when I say every 3 months, this is all AKIs now. We tell them first 1 year, 4 visits. If in these 4 visits they are very stable, we make them 3 visits in the next year, 2 visits in the next year. And then for the rest of their life, we follow them with 1 visit per year. In case they want to get pregnant, the biggest thing is how much protein loss is their baseline. If the baseline protein loss is 1000 or less than that, it is relatively easier to allow them to go for next pregnancy. And I should know the cause of that protein loss also. You may remember the patient who came to you with 3 point something creatinine. So that patient is already evaluated, protein loss was massive. Left to us, we wanted to terminate, but the family didn't accept. But by God's grace, they have a healthy baby and mother is also okay now. So most of our patients who come to us with 2000, 3000 protein loss, we try to discourage them from further pregnancies. And most of the times we take help of the obstetrician or gynecologist to tell them, please don't proceed, because one is regarding the mother, but we are also worried equally about the child who is born to them. So much of data now, if there is a premature delivery, these children become hypertensive very early. They become proteinuric because they hyperfiltrate. And because of the low birth weight, they also have low nephron mass at birth. So they become CKD patients in few.
So coming back
Okay.
to ma'am, any other comments from your side, your experience on cases like which has been referred to us with an AKI and all that, saying this is sepsis and multiple antibiotic were pushed. Then we find them to be having a normal pressures, no source. Then we actually further evaluate, we land up in one of the reasons for this AKIs which we are discussing. So even though sepsis is not uncommon in the peripartum period, but most of the time when the AKI doesn't recover and the patient continues to be in anuric or oliguric, there will be ongoing antimicrobial sedation and been transferred to us as saying this is a patients with sepsis. Is this been a common scenario you have seen, ma'am, or any experience on that side?
Yes, sir. I think recently we had one lady who was referred from Kadapa. She was a doctor by herself and she had a severe respiratory disease actually. And obviously when she came, she presented with the neurological symptoms. And on the scan, it was diagnosed as query she is having cerebral venous thrombosis. But after she was admitted to the ICU at Yashoda here, then after that, we could find out that she is having severe chest infection. And because of that, and her urine output was reduced. But obviously that sepsis was treated effectively, and obviously we could treat her with the fluids, and her urine output, everything went up. But creatinine levels were not that much high at that point, sir. And I think in the sepsis, I think it's very important that we have to replace them with a good amount of the fluids as soon as possible to prevent them to go into the AKI, sir. That's what I have observed in the sepsis cases, sir.
Rajasekara sir, coming back to you, even Dr. Sunil Pandya sir has pointed out a volume replacement. So we have been talking in the, at least those where a nephrologist or intensivist is standing and resuscitating a volume. Is still a volume deficit is a problem, or volume overloading is a problem in these patients?
So I think both are a problem. If you have a AKI and the intravascular depletion is there, you want to fill up the intravascular compartment. Volume overload is a huge problem, both mortality and morbidity and non-recovery of renal functions. Now we know that very, very clearly. So I believe these patients have to be seen more often, and because intensive care people are there all the time, every few hours they have to be reassessed. And the most important thing with most of us don't do is the cumulative fluid balance. From the minute the patient enters your hospital till the time you see, if the charts have a proper cumulative fluid balance, you can easily know is the patient 5% of the body weight already overloaded or not. I think that will help. So we don't want them underfilled. We don't want them overfilled. Both have very bad outcomes.
Sir, last comment from Sunil sir. Sir, do you see the sepsis being a common diagnosis pushed into all AKIs and sent to us for overlapping?
See, if you ask me, majority of the time it is preeclampsia and hypertension related, but we should not undermine sepsis and septic shock also. And whenever you have sepsis and septic shock or shock of any origin, when the perfusion is impaired, then you need to have a targeted approach, because once you have sepsis as underlying cause, which is I would say not uncommon, and we need to work towards, like, if the one set of cultures are negative, then you need to repeat the culture, look at the constant source of really look at the source, probable source. Majority of the time it is pelvic source, but there could be other sources also, and linchpin the diagnosis. But importantly, as Rajasekara rightly said, when I say advanced hemodynamic monitoring, what I meant also was frequent assessment, and always keep isovalence or slightly negative balance from the second day, at least from the, if not from the first day, but at least from the second day isovalence, so that we don't overload these patients also, because both the things are dicey.
So we started using a renal register index also nowadays. Some of our DRNB students are doing research on that, how additional of renal register index helps in the volume status and filling in them. So I was just adding to that, sir. Yes, as you said, preeclampsia, eclampsia are the common causes. Adding to that, sepsis or infection in many situations adds the cause for AKI. I was also trying to point out that we have seen good number of cases which has been referred to us as a sepsis, and multiple antimicrobials were given. They turned to be something like a TTP, they turned to be something like a HUS later on, which actually responded to your plasma exchange or a form of therapy. So these differentials should be also a part of, if all our for sepsis are negative. So that's what I was trying to find.
If the things, they don't work on your lines of diagnosis, clinical diagnosis, or even those laboratory assisted diagnosis, you need to open up your differentials and linchpin the workup further, so that right diagnosis is done.
I think it's
another important thing is what we have also encountered. Like initially, yes, we used to be aggressively sending NGAL and cystatin. Of course, the cystatin still is not easily available, but those markers, biomarkers of acute kidney injury, again, are not very reliable in pregnancy. I don't know about non-pregnant patient, but Kim molecule, Kim1, and all those things. I don't know. Rajasekara would like to throw some light on this.
Very sensibly just avoided that controversy, saying we don't know. How do we pick up? Rajasekara sir, do you want to answer that? You have not answered our question. How do we evaluate a
biomarkers
AKI in a pregnancy if you're saying creatinine is not ideal?
The only biomarkers which have published role in pregnancy are SFLIT and NGLIN. So both of them, Ravi Tadani's group initially looked at randomized trial around 20 weeks or before that. I think 8 weeks before actual preeclampsia sets in, these levels go up. So they also did plasma for removal of these factors and showed that when they removed them, the outcomes are much better. So these are the only two biomarkers which are useful, and they are not in routine clinical practice. All the others may have a role in a particular patient because of other confounding factors, but for routine clinical use, your frequent monitoring, output, creatinine to some extent, acidosis, and whatever the list that I gave, they are the guiding factors for us to intervene as early as possible.
Okay, so I think we are passing almost an hour, 10-15 minutes. So we thank all of you, Dr. Rajasekara Chakravarthi sir, for that excellent presentation and the overview of all the pregnancy-related AKI. I thank Anitha ma'am for being here and giving that insights. Dr. Krishnaveni ma'am, in spite of her being an emergency, she could actually pitch in and give some points. Dr. Sunil Pandya sir, we always been looked at you whenever obstetrics critical care came into light. So your learning experiences for us has always been helpful and is a guiding source for us, sir. Thank you all for the participation.
No, Venkat, I have a message for Sunil. Like in care, they should send us work now also. We are good enough even now, and our critical care team is geared up to take care.
Certainly. Yeah.
Thank you, sir.
Thank you.
Thank you, sir. Thank you so much, sir.
Thank you, Dr. Anitha and Krishnaveni.
Thank you, sir. Thank you, Sunil, sir.
Very nice presentation, sir.